Without further ado, I'd like to introduce today's moderator, Tom Sullivan. Tom, you now have the floor.
Thank you, and welcome everyone. Again, thanks for attending today's Learning Center webinar, Data versus Information, Myths, Realities, and Why More Data Isn't Better, sponsored by Medicomp Systems. As noted, I'm Tom Sullivan, and I will serve as your moderator today. We look forward to your questions and comments, which you can submit at any time by accessing the question box on your screen. And please know that we'll make every effort to answer those questions during today's live Q&A. The learning objectives for this presentation are explain why more data at the point of care doesn't always enhance interoperability or translate into better care delivery, examine the current state of data in healthcare versus the hype, and why the garbage in, garbage out phenomenon puts patients at risk. Also, to create a business case for introducing a physician-friendly clinical data engine by assessing productivity as well as opportunity costs. Our speakers today are David LaRoe, Chief Executive Officer of Medicomp Systems, and Dr. Jay Anders, Chief Medical Officer, also with Medicomp Systems. With that, I'll hand it over to you, David, to begin the presentation.
Thank you, Tom.
Thank you.
Medicomp's mission is to provide clinical content to clinicians worldwide and tools that they can actually use at the point of care to improve outcomes, meet all requirements, support interoperability, and as we move into this new role of using data for things like artificial intelligence, machine learning, etc., how do you do that? A few fast facts about Medicomp. For 39 years, since 1978, we've been working with clinicians and asking them, when you are in front of a patient trying to diagnose, treat, handle complications, sequela, particularly patients with multiple conditions, what information do you need in front of you that doesn't slow you down, get in the way, so that you can do your job? And the way we approach this, for 39 years, we've been interviewing clinicians and saying, when you're treating somebody, say, with chronic renal failure, what are you thinking about? What are the symptoms? What history do you care about? What would you cover in the physical exam? What tests might you order or results might you review? What are the therapies you would consider? What are the comorbidities? What are the sequelae? If you're treating somebody with renal failure, you might be thinking about diabetes and hypertension also. You'd be looking for edema. You might want to order a creatinine or a BUN level. You might want to know if they're taking they've been taking non-steroidal anti-inflammatories for a long time. Physicians go to medical school to learn this stuff, and then they refine their knowledge through years of experience. So we decided in 1978 the best way to build something physicians can use is to ask them what they need. How do they think at the point of care? What information do they use for various clinical conditions in order to treat the patient? What information would they want to share with another clinician? All of that. So over the years, we have built a structure with 330,000 clinical concepts, which are, for those of you who are informaticists on the line, they are pre-coordinated clinical concepts. Like headache at the front of the head, a frontal headache, might indicate for sinusitis, whereas headache somewhere else might indicate for another problem. We've done this, and in doing that, it's taken 39 years to build 100 million clinically intelligent links in our engine so that a provider at the point of care can click on a problem or click on anything and see the things that their colleagues for 39 years have been telling us are relevant. So that constitutes the core of what we call the Quip Clinical Data Engine. To make it usable in the current environment, of course, with FHIR, the Fast Health Interoperability Resources, it needs to be mapped to the national and international terminology standards like SNOMED, because that's how information gets sent back and forth, but doctors don't think in terms of SNOMED or RX norm or LOINC. They think in terms of, what am I treating? What do I need to see? So we have, since 1997, built into our engine probably more than 1.2 million links and mappings between our engine and our concepts and the standardized terminologies and code sets used throughout the world. There are now about a little over 100,000 active users around the globe using this at the point of care every day, adding their input to the curation we do with our clinical consultants. Our agenda today will be a thank you to Tom for the introductions. We're going to talk about the current healthcare need for data, what that might do in the future for interoperability, where we are today, what's about to happen when people start sending information back and forth, what that means for the quality of what you receive versus what you do and the quality that you send out, garbage in, garbage out. And Jay Anders, our Chief Medical Officer, will be talking about how do you make all that information actionable without slowing the physicians down or nurses down and getting in their way, and then what do we do next? But right now, even in a system, one of the large systems, data is siloed. Data is in the lab results are in one bucket, the meds are in one bucket, there's a problem list that gets updated but very rarely maintained. And up until now, you couldn't even send that information back and forth. You couldn't find it in a record, but now we are moving to the point in our sort of development as an industry where people want to start sending this information back and forth. That could lead to a lot of duplicate data, and even now, in a system, as I said, it's difficult to find the data to treat renal failure versus sinusitis versus cancer, even if it's on one system. Just imagine how it's going to be when these systems open their silos and start dumping it and sending it to each other. So there's a fractured system. It's going to impact continuity of care. It's going to impact outcomes. It's going to lead to medical errors due to poor communication. And now that we're talking about coordination of care across settings, across providers, moving from acute care to step-down units, to home care, to primary care, sending more information that's not structured or actionable back and forth is not going to help anybody. I'm going to pass it back to Pat McCrae. And Pat, do you want to talk about this polling question?
Absolutely. Thanks, Dave. We do have a polling question on the screen right now, and we do appreciate everybody's feedback. We're going to go ahead and collect all the feedback. We will be asking 3 polling questions today, and we will be presenting the results to each of these polls at the end of today's presentation. So our first polling question that we'd like to get a little bit more information from you on is, what are your biggest data-related challenges? You do have the ability to select multiple responses. Those responses are, we have too much data, we don't have enough data, the data isn't accessible to us, and we can access the data but can't find the right data at the right time. So again, if you would select the appropriate responses for those and hit the submit button at the bottom of the poll, we would appreciate your feedback. And again, we will be asking a couple more polling questions a little bit later in the presentation as well. So we'll leave this open for another 5 seconds or so to get your responses, and then we'll move on to the next slide. Excellent. I'm going to go ahead and close the poll in 3, 2, 1. And with that, I'm going to hand the presentation over to Jay to continue our conversation.
Thanks, Pat. When we talk about interoperability and analytics and AI, I'll get into that just a little bit more later in the presentation. When you talk about the promise of interoperability, I'm going to harken back to my old days in a clinic of 125 multi-specialty groups, and we were all on paper. We had a wonderful chart tracking system that would tell us where this particular chart happened to be, and we would have locations such as Dr. Smith's trunk of his car. So we'd have to go out to Dr. Smith's car and get the chart out of that. So we had a hard time even getting the paper chart to go back and forth. But now we have electronic healthcare. And we want to be able to take those electronic pieces and start to interchange those. This is really hard to do for a couple of reasons. There are problems with the standards. Dave talked a little bit about the FHIR standard and how to interchange data there, but there are multiple other standards of which no one has really chosen which one we need to transmit this data in. Data exchange as it exists today can be anything from something that's fairly granular, meaning a problem list or medication list, but it could also mean a whole batch of faxes or a whole batch of electronic versions of dictated notes, which makes it very, very difficult to start to decipher that information. It's inconsistent. There are no industry out there that wants to own the fact that we can start to interchange this and make a business model out of it. But as a clinician, one of the things that has bothered me for a very long time, even back in the old world, was a test that was run 24 hours ago I didn't have access to, and I would repeat it. Somebody went to the hospital emergency room and they were weak, maybe they had an upper respiratory tract infection, and somebody ran a CBC. They come into my office and follow up, they still look kind of sick, maybe they're a little worse. I didn't have access to that CBC, so I ordered another one, just to see what it is, but I couldn't even compare it. Did it get worse? Did it get better? What was it? I couldn't have access to that. So if we do have good, true interoperability, those kind of things would be reduced, and they'd be reduced quite a bit, I believe. The other thing is interoperability allows a lot of folks of the care team, and that's where we're headed here, is it's a care team. It's not just your physician anymore. It's your physician, the extenders of that physician, home care, all of the other practice settings that Dave talked about. They all need access to the same information out of a medical record to adequately assess and treat a patient. If they have that information, they'll deliver better care. So allowing interoperability across an enterprise, not even between institutions, but across an institution to all of those clinicians that are going to be taking care of people is very important. The other thing with duplication of data and systems having medical errors built into them and reducing mortality, if I would have access to a patient's prior set of medical data, I absolutely am certain that mortality would be reduced, simply because we will catch things more quickly, more frequently, and patient care will be enhanced. And what I mean by that is, talk about women's health and mammography. So women need to have that test on a regular basis based on their age and clinical history. But if it's not done, you need to know that. If it is done, you also need to know the results of that and whether it's abnormal or normal. And if it was abnormal, has it been followed up on? If we could really interchange data, those particular types of tests would not fall through the cracks. Now, currently, like I said, there's no real business model out there to support interchange of medical information. There are business problems. There's no really good reason to do that. And there's also the liability problem. I'll talk about this a little bit later as well, meaning that if you receive a whole batch of clinical information from another source, another clinician, a hospital, you are now responsible for that, even though you may not have the chance to even read all of it. So if you look at the way it's done today, you may have 50 pages of free text, of which the information is buried in, and you've got to decipher through that. And someday you may be held accountable as a clinician, to making sure you knew what was in that medical record. Because if you missed something and an untoward event happens, or even worse, a mortality, then you're going to have to explain the fact that you had that data in front of you, but you didn't even look at it or couldn't find it. So let's talk a little bit about the promise of interoperability in analytics. We hear a lot today about Watson, Google DeepMind, other analytic platforms that are out there, what I believe really starting to do some kind of amazing things. These systems have a great capability to really enhance the practice and advance the practice of medicine and treatment of patients. What they lack is good, solid data to base that on. And what I mean by that, and we'll talk about this also, is the fact that if you have garbage in, you're going to have garbage out. So if the system has not been fed appropriate information, say we're treating colon cancer, there is a lot of genetic markers for colon cancer, there are sequelae for colon cancer, family histories of colon cancer. All of those are discrete data points of which someone has to collect and feed these intelligent systems so that treatment protocols start to become enhanced and the care is advanced and we start to develop best practices. So these platforms have great potential to actually do that, but they're getting a lot of garbage right now. You can't really go through and feed one of these systems free text without some clinician who understands the condition, breaking it down into the discrete data points and feeding that into the platform that it was intended for. So it really is a problem of what kind of medical data needs to be interoperable, number one, and also, number two, being able to be feeding into these wonderful AI systems so we can actually get benefit of those systems at the point of care while the clinician is standing in front of the patient and has the ability to actually intervene and move that care. So I'm going to turn this over to Dave.
So today, I noticed in the registration list there are quite a few people who probably have suffered through the promotion of HL7 as a mechanism for exchanging data, and everybody sees where that got us. Okay? Now, the advantage to FHIR, Fast Health Interoperability Resource, is it's a fairly well-defined set of APIs to exchange data. The industry seems to have made a commitment to it, and we believe that it is the wave of the future in enabling systems to package stuff and send it to somebody else to deal with. So FHIR has the capability to contain just about anything you want to send to somebody, and once they receive it, as Jay said, it becomes the recipient's problem to figure out what it is. So I call that stuff, and there's some data in there. There's a lot of free text, but there's a lot of things that the recipient, particularly the poor clinician at the point of care who's now received this stuff and is responsible for it and says, I'm treating the patient for, I think it's a thyroid condition, how do I see the information on that? So it's good to have a mechanism to send information back and forth. Not so good when that envelope contains things you can't deal with. I mean, I have some very nice monogram stationery, but if I open that up and I just throw dirt in the envelope and send it to somebody, they're not really going to appreciate receiving it. And so think of FHIR as a fairly advanced set of protocols and envelopes that you can put something in, send to somebody else, and when they receive it, it's up to them to figure out what to do with it. And so when analytics engines or population health engines or machine learning engines get all this stuff, what are they going to do with it? It's going to be very difficult to do anything with it clinically if it's not good, structured data that's meaningful to clinicians. Right now, we have an envelope and a means of sending things back and forth, and our systems are pretty good at identifying billing or claims data. They're really good at that. And that reflects the still current, I think, but supposedly about to change protocol of the more encounters you have and the more progress notes you write and the more procedures you do, the more you get paid. So you do a progress note, you say, this is what I did, this is why I did it, and you get paid for that. So we have great infrastructure in place to track billing transactions in an encounter, and in fact, our industry right now is dominated by architectures built to do just that. Not treat people over the continuum of care, not create better outcomes, but you go to any successful hospital administrator and they're really proud of how many beds they have filled every day. That's how they get compensated. Those systems still dominate, but we are supposedly moving into, and this is what part of what meaningful use is all about, force people, give people $35 billion to build these systems to give us better data, better outcomes, etc. That's going to be based on clinical data, not billing data. The billing data is a start. Now we know what we did, but how do we actually use clinical data to do analytics, value-based care, outcomes, etc.? So it's nice that we have FHIR. It's nice that we can put anything in it. It's nice that we can connect two systems electronically and digitally, but what is in that container that they receive, and how are we going to use it when we get it? Because clinical data is different than encounter notes and progress notes in order to justify a billing transaction. I'm going to send it over to Pat for our next poll question. Pat?
Excellent. Thank you very much. As you can now see, we have our second of the three polling questions up on the screen. The next thing we'd like to ask you about is, what do you see as your biggest barrier to achieving true interoperability? We do have a few options for you to be able to choose from here. The first is it's difficult to exchange data. Second is it's difficult to organize the data that we receive. Third is it's difficult to apply the data and make it actionable. And finally, we're satisfied with our current state of interoperability. So if you would take a moment and respond to this poll, we'd greatly appreciate your feedback. Again, we will share the results to this poll toward the end of the presentation. And we do have a third poll that's coming up in just a little bit. So we'll leave this up for about another 10 seconds for you to go ahead and respond to. A couple other quick reminders while you're taking this poll. If you joined us late, we do have a PDF copy of the slides that can be accessed in the bottom center of the screen in the handouts panel. And this presentation is being recorded, and we will send a link to the recording to you after the event. So with that, I think I'm going to go ahead and close the polling question for this, and we will move on to our next slide. And for that, I will hand it back over to Dave.
So I started with where we are today in terms of interoperability, and 99% of the hospitals in the United States have EHR systems. Every one of those is hopefully getting ready to implement some kind of APIs and FHIR and send information back and forth, but even in those systems, our research indicates that 46% of the EHR data is copied and pasted. So that's just going to, propagate throughout the system when people start sending it back and forth. And what that leads to is about half of a doctor's time is spent looking through all this stuff, as I said, trying to find what they need. What are the lab results they need to review for this condition versus that? What's the prior treatment? Was it effective, etc.? Anybody who's worked on one of the big hospital EHRs knows that what I just described probably takes about 10 or 12 clicks in different areas. Some things are presented alphabetically. Some are presented just as free text. You've got to spend all this time with the patient, and now you're reading the chart, or you just don't look for it at all. You just say, okay, I can't find it. Now, the vendors are putting out these big numbers about the number of times they've exchanged information, but what we're thinking about is, what's the quality of that stuff being sent back and forth? It's an awful lot of free text, and it's an awful lot of disorganized information that when the clinicians at the point of care are trying to treat the patient, how do they find what they want? And we're saying, here, we're going to help you. We're going to give you more stuff to sort through, and it's going to be spread in multiple buckets across this, and some of it's going to be duplicated, and some of it you're going to be able to find, but pretty much, I went to a physician a couple weeks ago, and he basically said, I'm going to have to ask you a lot of questions that I probably asked you before because it's easier for me to ask you and for me to record the answer than to look it up. I'm sure that people have found that. And it's gotten so bad that when you start talking to these docs, you see I have up here, and this sort of reflects the preliminary results of the poll, information is too difficult to find, and the software is not intuitive. I don't even know where to look for it. I don't know how to organize this. And it's gotten so bad that you see the second comment here, Mark Price, he lost his command of the English language, and instead of saying I do duplicate work throughout the day, he said duplicity work. So duplicity indicates he's blaming the system for that. It's like complicity. The system's complicit in the duplicate work that I have to do, so I do duplicity work throughout the day. And what he's saying there is the same thing my physician said the other day to me. I can't easily find your current list of meds, problems, etc. So let's go over it real quick. And then what did he do? He typed it in again. I am going to talk a little bit about where we are today. What are we trying to do? A lot of progress notes, as I said, a lot of dictation. A lot of people are relying and hoping that natural language processing is going to take all of this free text stuff that's dictated after the patient leaves or while they're in the other room, and we're going to refine it, and we're going to take all that complex information and we're going to reduce it to data. We have not yet seen any study that has less than an 8 to 10% error rate for taking speech to text to data. So I'm not going to accept an 8 to 10% error rate on my bank statement. I don't think most people want it. And even when that's done, even when it's 10%, and NL and natural language processing techniques find something, frequently they find the wrong thing. The patient is really depressed because their dog just died of cancer. There's no telling when NLP gets a hold of that who's going to end up with cancer and who's going to end up with depressed. The dog, the patient, a family member, etc. Health care data is complex. It gets more complex to interpret health care information dictated as free text and then mined by a technique that has an unacceptably high error rate. So you try to feed that stuff to artificial intelligence and machine learning engines. It gets worse. It gets more complex. It's these systems that are being designed. Jay mentioned Watson, Google DeepMind. There's others, population health engines. Some of these do fairly well at detecting patterns in a large population. But a pattern in a large population does not translate easily to something a clinician can use for a specific patient at the point of care. We refer to that internally as the big data versus little data problem. I got a whole bunch of big data information from my analytics platform about population. 87% of the population responds to this medication for this diagnosis, but oh, wait a minute, this patient has an allergy and they have 3 other comorbidities and it doesn't apply to this patient. Now what do I do? So I've got big data giving me trends for a population, but I've got little data. I got this one patient in front of me with a unique set of problems. How do I find the information I need? And if I find it, how do I send it to a platform where I can take advantage of artificial intelligence and machine learning, because that's what everybody's talking about. So where we are today is hoping, praying, wishing that natural language processing of free text is going to help give us the data we need to support these capabilities that people are starting to talk about. We have the ability to exchange information through FHIR. We have the ability to receive it. We don't really have too much that helps us deal with it with one patient at the point of care. So that's the bad news. Dr. Andrews will take us out of the ditch here, okay? Talking about what's going to happen and what do we do about it. We call this, Doctor?
The data tsunami. So think about this. For the practitioners that are listening, you get a chart back in the old days in your office. It's 2.5 inches thick. That was the old data tsunami. So I've got a new patient. I've got a 2.5 inch, 3-inch chart I've got to go through, and I have to find something in that chart and do something with it. It may be a particular thing. It may be a bucket of things. So on the screen, you see the Connectathon in 2005. They think 2,000 exabytes of data will be exchanged by 2020. Well, what the heck is an exabyte? I had to look that up. So an exabyte is 1 million terabytes. Well, I'm a clinician primarily. I work in the electronic healthcare world. This is a lot of data. And as that data starts to flow, and it starts to even flow in granular forms, it's going to be a lot to cope with. And what I mean by that is that systems are going to have to get smarter and smarter in assisting the clinician to actually decipher what's in front of them. So what do I mean by that? Give me the diabetic view of this particular patient's data while I'm seeing this patient for diabetes. Oh, by the way, they've got hypertension, they've got chronic renal failure, they have Lewy body dementia. Give me the views of those and all the interconnected data points that put those all together. Now, as a clinician, I can actually look at a clinical piece of information and the snapshot of where that patient is. The only way clinicians are going to be able to deal with that is systems have to get smarter and allow them to look at clinically relevant data, again, at the point of care, because it doesn't do me any good to understand that a patient needed something after they're already home. That means a phone call, that means calling back, that means they got to show back up in the office. There's a whole lot of reasons why the point of care becomes the focus of this. So not only are they going to have to deal with all this data, they're going to have to be responsible for it. And what I mean by that is, if there is an abnormal test buried inside a patient's chart and the physician misses it, it now becomes their responsibility. An example, I'll harken back to mammography. There's an abnormal mammogram. She's coming in to see me for another problem. All of a sudden, that abnormal mammogram is now my record, and I've not done anything with it. Now, the person who sent it also didn't do anything with it, but now we've got two people responsible. But the problem is the patient didn't get the treatment or the care they needed. The same thing could be said for diabetes. You could have a patient that's transitioning between care providers where they've been completely controlled under one care provider. They've been away for a while. Now they come back to the new care provider, and that person has to sit there and look at all that data to make sure where they are. Some of these things, like Dave said, you can't ask. You can't repeat. What was that blood test? What was the status of that particular renal failure condition in the past as opposed to what it is right now? So right now, the physicians have to deal with trying to find things in the chart, trying to correlate things in the chart, and like Dave said, it's going to be correlated by medication bucket, by data prescription, or by alphanumeric listing. It's going to be a problem list. It could be by date. It could be by SNOMED number. That really doesn't help the physician do what they need to do. There has to be a system smart enough out there to deal with the clinical striping of information and allow the data to be correlated in those clinical condition buckets to give the physician what they need to look at and focus them and filter out a lot of the clinical noise. And when you see an amount of data like is going to be coming down the pike for some of these interchanges, there's going to be a lot of clinical noise involved. I'm going to turn it back over to Dave.
So let's talk about the problem in this data tsunami, the quality of what you get versus the quality of what you pump out. If you look at a current chart, particularly those who rely on dictation, scribes, etc., it's estimated up to 80% of the information in a chart is unstructured. The stuff that is structured is usually, as I said earlier, diagnosis codes, ICD or SNOMED, CPT or HCPCS codes for procedures, for things that you bill, that old encounter progress note billing model, and the progress note, which is mainly unstructured, is meant to justify what you said the patient had and what you did about it. But the clinical information is mainly unstructured. I'm talking about the patient presentation, the symptoms, the relevant history, the fact that this patient has a history of hypertension, which is comorbidity of diabetes that could lead to renal failure, etc. All very important stuff hidden away. And the other thing that current systems and current approaches really don't handle well is negation. Somebody has no family history of brain tumors. Boy, I've got no family history of brain tumors. These systems do not handle things well, like negation or modification of a clinical concept to say the mother had breast cancer, the father had colon cancer. You try to do that and then negate that in SNOMED and present it to the physician at the point of care, I'm telling you, and Dr. Anders, do you agree with me?
Absolutely.
Not going to happen, okay? So if you want to do something with data, you've got to have good, clean, structured data that can be used at the point of care, used by analytics engines, etc., and you've got to somehow avoid massive data duplication as people send all this stuff back and forth. So the more structured and discrete your clinical data concepts are, the concepts that we've been working with physicians for 39 years to say, what are you thinking about when you hear diabetes, hypertension, hypothyroid, renal failure, etc.? Okay, what would you want to see? What would you want to know? What would you want to send to somebody? What would you want to receive from them? That's what we're trying to do. We're not just trying to find a diagnosis, but what's all the information you need in front of you to make the decisions you're going to make about the patient. And if we just send stuff through these pipes in these envelopes, people are going to be overloaded and not really know what to do with anything. So how do you, Dr. Anders? Well, you talked about clinical striping of data a minute ago, of information. You see on this slide, I've got sort of a replication of what a really good clinical data engine can do for you. It can take data, it can eliminate duplicates, and then you end up with a bucket on the third graphic over there of disorganized data, but how do you organize all that information by problem? How do you see the history, the symptoms, the exam, medications, labs, comorbidities associated with a particular thing that the clinician's thinking about at the point of care so that you can take action on it to actually improve outcomes? We call that, and I'll ask Jay to talk about this, making that haystack actionable.
Thanks, Dave. This has really been the problem for a very, very long time. And let me give you a clinical example of what I mean by that. So you take diabetes, for instance. There are treatment protocols for diabetes. There are controls for diabetes, hemoglobin A1C, foot exams, eye exams, making sure they're following a diet, etc. When all this data comes in, give me that diabetic view of that data. That makes it actionable at the point of care. The other thing that clinical striping of data does is that it also allows you to find something very, very quickly. So if I can code it down by a clinical condition, and as a clinician I'm already trained to know what those clinical conditions are and what the protocols are, I can actually find it in that incoming batch of data. That helps to make it actionable. Once you've done that, intelligent links can start to put things together, either for a population health management platform or an artificial intelligence platform, to start to make those neural networks work as they were originally conceived they would. So, again, what AI needs and what analytics needs is really great clinical data. And the source of that clinical data is the most powerful computer in the exam room. That's the physician's brain. They're the ones that are going to be able to decipher what things are and record them effectively and accurately, and then that information is actually what you transmit. So that creates the high-quality clinical data that you need. It starts to make those data links together. You put physicians, giving them the opportunity to start to look at conditions, decipher those conditions, and then reapportion that data back out again. So I'm going to turn it back over to Pat.
Excellent. Thank you so much. And with that, we are going to introduce our third and final polling question for the presentation today. This one is relatively simple for you guys. The question is, does your organization plan to use AI or machine learning technologies in the next 1 to 3 years? And the options are yes, no, and unsure. So again, we do appreciate any feedback or responses that you can submit for this polling question here. And as soon as we close out this poll, we'll go ahead and share the results to all 3 polling questions that we asked today so the audience can see the results to those polls. So we'll leave this open for another 10 seconds or so, and then we'll move on to show the results for all of our polling questions for today. And again, we appreciate everybody's feedback and responses to all of our polling questions today, as well as your participation in today's event. Excellent. I am going to go ahead and move on, and we will start by sharing the results to the first polling question that we asked today. That question was, what are your biggest data-related challenges? So it looks like the vast majority of our audience, about 49% of you guys had said that we can access data but can't find the right data at the right time. About 49% of you had said that, and then from the top to the bottom, the next was 28%. The data isn't accessible to us. About 10% of you had said we don't have enough data, and 6% of our audience today indicated that they have too much data. Moving on to the poll results for our second polling question. That question was, what do you see as your biggest barrier to achieving true interoperability? About 42% of you had said that it's difficult to exchange data. 19% of you said it's difficult to organize the data that you receive. 36% of you said that it's difficult to apply the data and make it actionable. And about 3% of our audience today indicated that they're satisfied with the current state, their interoperability. And finally, for the polling question that we just asked, polling question number 3, does your organization plan to use AI or machine learning technologies in the next 1 to 3 years? 23% of you said yes, 17% of you said no, and about 59% of you are unsure. So again, thanks everybody for responding to those polls. We do appreciate that. Hopefully you found those results insightful. And with that, I'm going to move forward and pass the presentation back over to Dave.
Okay, so where we are now is we're on the cusp of being able to use new technologies to take information out of these electronic systems that the government has pumped out somewhere around $35 billion over the last 7 years to get people to implement. And now the requirements are saying, and you have to be able to exchange data through certain technologies that are maturing, like FHIR. But what happens next if we just turn on the spigots right now? If we turn on the spigots right now without better, clearer data and tools to use it at the point of care, then physicians are going to become, and nurses and patients are going to become overwhelmed with information that they can't do anything with or act on or even find. I think some of the polling questions showed that one question said, we have trouble finding what we need at the right time. So we do more of this, it's going to get worse without better structure for the data. This is going to lead to, and Dr. Anders referred to this, once you get this data, you're responsible for it. Some health systems are going to say, we don't want to get it. we don't want to receive it because we can't do anything with it, and now we're responsible for it. Please stop sending us this stuff. Okay? And there is the potential for HIT vendors to create monopolies around their data on their sites and exchange them with each other sites of the same vendor, but not with anybody else. So those are some challenges. And one of the things that we're starting to see, that we're starting to get interest from, is the analytics vendors, the artificial intelligence, people who are looking at machine learning. They want better data. They're starting to demand for their platforms to be effective, higher quality, more discrete data to receive, to send, and to do something with at the point of care. So we're starting to see that, and what can we do now? Okay, people out there can insist that the data infrastructures that they're using improve, and if people believe they're actually going to get there through free text, dictation, machine learning, or natural language processing, etc. I've been hearing that for 5 to 20 years, that this is the answer, etc. So what can we do now? I think we all have to invest and find out how are we going to bring all of these technologies that are coming together at the point of care so that clinicians can focus on the patient, find what they need when they need it, send it to people in a format that it can be acted upon when they receive it. And some of the benefits of that will be less duplication of data. You'll have better outcomes. Again, we're in the middle of what's supposed to be a fundamental shift between justifying what we did during one encounter and a progress note and getting paid for that episode versus managing a population, accepting risk, and being paid for value-based outcomes and sharing information across the continuum of care and time. So it's only by better use of data for all people involved that we're going to get there. So I'd like to summarize on that point and turn it back to Tom Sullivan for a few minutes of Q&A.
Thanks, David, and also thanks to you, Dr. Anders. We do have some questions in the queue, so in the interest of time, I will jump right in. At the top of the list, does your data engine integrate with any EHR system?
Yes, the Quip Clinical Data Engine is currently in about 14 different EHR systems, and we've built it to do that. I'll give you an example. When people hear Clinical Data Engine, they assume that means that we're hosting it in the cloud, we're storing the data, we own the data. We are pure middleware. We are a middleware engine with a user interface on the front end that's designed to be integrated in other people's EHRs. So, Tom, did I answer your question?
You did, yes. And as kind of a follow-up, another audience member asked, you mentioned that AI and machine learning systems need to be built on top of expert systems, and the attendee is asking what precisely you mean by expert systems.
I don't, maybe Jay said that. I don't think I said that.
What I mean by an expert system is an IBM Watson, a Google DeepMind, one of these neural network-oriented systems that's geared to have the capability to organize and use information. So the data structure that goes into them is what that system absolutely needs.
And I just went to a presentation by Dr. Dominic King, the clinical lead for Google DeepMind out of the UK, when I was at HIMSS Asia Pac in Singapore. And one of the things that he said is that the purpose of their whole machine is to look at what's happened in the past to determine what's likely to happen in the future. And he said, you need really good, clean data models to do that, to filter out the noise, etc., so that the analytics platforms are getting to the point, as I mentioned, where this can be done for a population to detect patterns. But what they're trying to build and what IBM Watson is trying to do and some others, they're trying to say, for this specific patient, how do they compare to the other patients we've seen? How's their data profile the same or different so that we can learn from what was done in the past and improve what happens in the future? That's really what that's their definition of one of the things they're trying to achieve with an expert system.
Understood. And now, building on that, one of the questions in the queue here is, what is the first step to creating structured data?
This is going to sound, I don't want to sound like a wise guy, a smart aleck, but you've got to design the data for the use for which it was intended. Okay? And for example, SNOMED was intended to classify clinical information post-acquisition. Okay? Our goal is to deliver data in a format that's both actionable for use at the point of care by clinicians based on the way they think and work and their own workflows, and to map it to those things in the background that are needed for other means. ICD for diagnosis and SNOMED for clinical information, CPT, etc. So there's no one data model that fits for everything, but our goal and the reason that we built it the way we did is we specifically designed it for use at the point of care by interviewing and talking to and curating it with physicians for the last 39 years. So it depends on what you're using it for.
So a slightly different topic here, but an audience member is asking about how much noise is typically in claims data and what's the value of claims data at the point of care.
This is Dr. Anderson. I think that claims data at the point of care is absolutely useless. Number one, it's based on half information usually, and it's a very coned down piece of information that describes what's needed to satisfy a claim. It certainly isn't the amount of information needed to satisfy the clinical condition that a clinician needs at the point of care. After going to medical school, residency, and 20 plus years of medical practice, I didn't go to those places to file a claim. I went there to take care of patients. Systems need to be designed to allow physicians to do that and let the claims process flow out of that in the background.
Got it. So another attendee here is asking, garbage in, garbage out. It's true for algorithms as well as human brains. Do you think data literacy in the healthcare setting is critical for overcoming some of the barriers you discussed today?
Well, wow, that's a really good question.
Great question.
That's a deep question that I find exciting and a little depressing. Data literacy, again, is probably minimal in our industry regarding usability at the point of care. It's not bad for classifying transactions. It's not bad for, as I said, detecting trends in a population based on claims data, diagnosis, etc. I don't think users need to have that much data literacy. They just want to see what they need. They show me what I want to know when I want to know it. Don't make me look for it and don't waste my time. And it's up to the people building systems and supplying technology to them to be the ones that are literate enough about the way physicians use data in their own thought processes to make sure that what they see when they turn to a screen reflects the way they think. That requires a pretty deep understanding of data literacy. And I'll just give you an example. When our founder, Peter Goltra, started working on this project in 1978, it took him 7 years and 3 complete redesigns of our data model to get to one that could support the way a physician thinks at the point of care. Not replace, not replicate, but support. So That required a deep understanding of data literacy and what actually happens in those thought processes at the point of care, but it doesn't require, if it requires data literacy on the part of the clinician, then you're in trouble. My opinion only.
Since we're approaching the top of the hour here, I'll sneak in one final question from the audience before moving to closing thoughts. Here comes the question: do you see a need for a national or even international standard of metadata management and schema?
Absolutely. There has to be a standard by which people need to transmit their information, what that information looks like, what's included in it, what buckets it's transcribed into. Without a standard, then people are doing what they're doing today, which is throwing out just pieces of electronic paper and med lists and just little snippets of stuff. So, yes, there needs to be a standard. It needs to be defined. It needs to be defined on the scope of medical data. What I mean by that, all domains, history, physical, diagnoses, tests, therapies, all of those things need to be included in that standard in such a format that the physician can consume.
So as we are now, as noted, approaching the top of the hour, I will give each of you a chance to just share some closing thoughts, top takeaways, what attendees should leave today with. So Dr. Anders, why don't you go ahead and start us off, please?
Well, one of the things that has been one of my issues for a long time is being able to find information in medical records so that I can adequately treat patients. If anything needs to come out of this, we need to start supporting physicians with data that they need and desire at the point of care and get out of the fact of big data, population health management, trying to look at the population of all my patients as opposed to the population of the one patient I have in front of me.
Interesting. Now, Dave, final words of advice for our attendees.
Final words of advice. I know a lot of the attendees are from institutions actually caring for patients, and I would just say keep a close, as things develop over the next 18 to 24 months, keep a close eye on whether the people who supply your systems and the docs who use them, are they given the providers, nurses, doctors, etc., what they need to treat patients at the point of care, and if not, what are they doing about it? Okay? And bringing more information in isn't going to do it. It's going to be how do you give a provider the right information for the right patient at the right time for the specific thing that they are thinking about. And if they can't do that, frustration is going to increase, and the systems just increase burdens on everybody, and they don't really improve outcomes.
Excellent. That's a great way to wind things down here today and wrap them up. I'd like to thank everyone for tuning in. Please be sure to complete the evaluation and share your thoughts with us. I'd also like to again thank our speakers, David and Dr. Anders, for taking time to share their expertise with us. Today's session will be available on demand until January 10th, 2018. Thanks again, everyone, and have a great day.